Good morning, everybody. Good evening, everybody. And we have a lot of people today. So thank you, every single one of you, for coming. And I know it's late for our friends and colleagues in Tanzania. Here in the US, 11:06. So, and thank you for giving us our Friday, just a little part of a Friday, so we can you can help us get this logistic in a way, because it's only 20 days left. I feel it's like next week. It is so many things, but I'm grateful and thank you, everybody. And I know probably you've seen and heard from me, and a lot of you have been responding, so I appreciate. I know we go back and forth, but to start with, my name is Dr. Harriet Gabone, and I'm CEO, founder, president of QHSC. QHSC is Quality Healthcare Solutions and Consulting. And we have been organizing medical mission for almost 4 years now, but known by QHSC, this will be the second medical mission. So last year we came in Tanzania and we went to Dodoma for 2 weeks, but this time we graciously plan to come and see people in Dar es Salaam. And in Dar es Salaam has been an exciting way because we're going to reach a lot of people. So we are going, as of now, before Dr. Mkonyi squeeze me, we are working with 4 hospitals and still adding 2 more hospitals. There's a lot of logistic things that are going on behind the scene. And I know most of you are not previews for that information. But with this information today, we're going to share as much as we can. And as I said, things are still growing, and we really appreciate the Ministry of Health and leadership management stakeholders of Tanzania who make the decision for those different hospitals, agreeing for us to go in there and try to share our best practice and also learn from our colleagues in Tanzania, their best practice in addressing Help Baby Breathe and postpartum hemorrhage. So majority of the discussion today is going to veer probably more like to postpartum hemorrhage, because at least for Help Baby Breathe, we're at the point that it's a great part, and thanks to Dr. Msambi Chaka and Dr. Fabian for working tirelessly to make sure that program is standing still. And for postpartum hemorrhage, Dr. Gwen and I and Mr. Jafari and Dr. Emma, we've been working quite a bit to try and get the postpartum hemorrhage training that is applicable and influential in Tanzanian side. And so some of the devices have been added to that program in order to make sure we use our best practice both places to make sure we improve the clinical practice of our nurses and doctors in Tanzania. So I know we have quite a bit of the group here, and I'm gonna let everybody at least take like 30 seconds, introduce yourself so we know who is here and who we can know that when we are discussing and asking questions, then we know who we are addressing those questions from. So on my right side is Miss Victoria Jones. If you can say hi quickly and explain your role in this QHSC.
Hi, I am a burn specialist, and I'm glad to be aboard. Good morning and good evening to you.
And also she's the board of directors for QHSC. She always being humble, but she works behind the scene quite a bit. So thank you, Miss Victoria. And she's coming this medical mission in 20 days. She's gonna come and work with Muhimbili, working with Dr. Mrema, and try to educate for the burn area there. On my left, Mr. Prank.
Harank Siakabe, Vice President, QHSC. Good morning and good evening, everybody. Habari ya subuhi na habari ya usiku.
Jioni is not usiku yet, but it's okay. Very good. Okay, Dr. Tilia, thank you very much for coming. If you can give us a little brief, please, and I'm going to give you another time to talk later. Dr. Tilia.
Hey. Habari ni za asubuhi.
Nzuri.
Habari nzuri. Yeah, I'm Robert Tilia, working at the Fakara Health Institute. I'm glad to join this team this evening, and I'm ready to share with you what I have concerning the use of non-pneumatic and shock garment. Thank you. Asante sana.
Karibu, Robert.
Thank you, Dr. Tilia. Mr. Nicodem?
Asante.
Yes, my name is Nicodem Komba, and you know me, we have been meeting here sometimes.
Yes.
So nice to be here.
Thank you very much. And Mr. Komba also is working with us and trying to help us with sterilization and cleaning of the NSG. So just to learn the process, what is required. So when we finalize the process of from one area to the next, who is going to be responsible for the NSG, we need to be able to know who is going to be cleaning and make sure it's ready for the next patient. So thank you very much. And we're going to hear from Mr. Nicodem in later on this meeting. Ms. Vicky?
Hi, I'm Vicki White. I'm from Tennessee. I'm a nurse. I'm a baby nurse usually, but I don't know what I'll be doing on this trip, but I'll trying to help the best I can.
Thank you very much, Ms. Vicky. She's going to help us with this postpartum hemorrhage also, and also she's going to be teaching, and also she's going to be there with us for the medical mission, her first time to come to Tanzania. So we're trying to acculturate her to Tanzania things and teach
Dr.
her a few
Gaboni.
words.
Dr. Gaboni,
Yes.
I just got the message about 2 minutes ago that my visa was approved.
Yes. Let's go. Let's go. Stop parking. Let's go.
Okay, I'm ready.
Good. Thank you, Ms. Vicky. Dr. Mkonyi?
Hi everyone, my name is Martha. I'm actually in Tanzania working at Muhimbili National Hospital. I'm a pediatric neonatologist working in the neonatal unit. I'm glad to be in the team.
Thank you very much and welcome. And Dr. Mkonyi has been an instrument on the background, and she's working so hard to help us and make sure this NSG training is success. So thank you, and we're going to give her a few minutes later to discuss part of it. Ms. Teresa?
Good morning and good evening, everyone. I'm Teresa Cooper from San Francisco. I'm a food and nutrition scientist, and this is my first trip. I'm really, really excited. I'll be helping Miss Kristen in teaching nutrition lessons in the schools, and hopefully, doing more later on for building a feeding program for the kids. So I'm super, super excited to be going on the trip. Thank you very much.
Thank you very much, Ms. Teresa, sorry. You're going to see her a lot. We're going to adapt her, and we probably keep her in Tanzania for a little bit longer than what she's expecting. So that's okay. Okay, Mr. Jafari.
Yes, I'm here. Hi, everyone.
Okay, good.
Good morning.
Good morning.
Yeah, my name is Jafari Utavi. I'm a midwife from Muhimbili National Hospital, but also I'm a national facilitator for neonatal and maternal health. So I'm happy to join you guys, and we're here to hear more from you. Thank you.
Thank you very much. Mr. Jafari has been a constant fixture in our meetings, QHSC. We already adapted him, and although he claims he's from Muhimbili, but that's okay. He's going to also help us quite a bit with the postpartum hemorrhage training. So we've been discussing back and forth, learning about how to use the Mama U and all the stuff. So you're going to be seeing him quite a bit. Thank you very much for all you're doing, Mr. Jafari.
Thank you, Dr. Harriet, and sorry for claiming for just Muhimbili, but I'm a part of team of QHS.
Yes, we already adapted you. Okay. Mr. Prank, are you raising your hand? Or?
No, I'm clapping for Jafari.
Oh, yes. Thank you. Last one, Rio. Last one, can you introduce yourself?
Yes, my name is Laston. I'm from Desire Hospital. I'm the first to participate in this meeting.
Which hospital did you say?
I'm Laston from Desire Hospital.
Oh, Desire, okay. Oh, thank you
Yes.
very much. We appreciate. Karibu sana.
Asante sana.
Yes, we are looking forward to seeing you more and learn from you and hear your feedback, because remember, whatever we are discussing our best practice, we want to make sure it works in Tanzania. So,
Okay,
so thank you for coming, and we're looking forward to working with you.
Thank you.
Okay, Sangalala. Can you introduce yourself, Sangalala?
Hello, my name
Hi.
is Sankara. Hello. This is my first time to join you. I'm from Amana Hospital, HOD, OBGY.
That's why Mr. Kiwel was talking about. Thank you very much for coming from Amana. Definitely, we need your help. We need your participation to make the NSG transfer from one hospital to the next effective. So thank you for coming here, because you're going to give us the practical things that will work and make logistics of that process work effective. So thank you for coming.
Thank you very much.
Okay, Miss Agnes.
Hello.
Hi.
My name is Agnes Dongo. I'm a midwife from Ubungo District Council. I also work with Tanzania Midwife Association. And also I am a mentor on a respectful maternity care. Thank you.
Nice. Thank you very much. I know you came before, now you're coming back. So we need your help. So keep coming back. Okay. Thank you. Dr. Ngido.
Hi, everyone.
Hey, somebody's working.
Yeah, always. My name is Fabian Gido. I'm a pediatrician and pediatric hospitalist, and I'll be working mainly with the newborn helping baby breathe, and with whatever Dr. Gabon wants to assign. But pretty excited to go back.
Yes, I'm looking forward for that. Yes, he claims he's the pediatrician, but we're going to make him participate in postpartum hemorrhage too. He doesn't know yet,
Yeah.
but you can't just have a baby without a mom. So mom needs to be safe first before you can have a healthy baby.
Sure, I'll learn.
Good, we'll teach you.
Yeah.
Thank you, Dr. Ngido.
Thanks.
Mr. Steve Jones.
Good morning, everyone.
Good morning.
Yeah, there it is. Good morning, everyone. I am Steve Dr. Well, that's not fun. That's not funny. I am Steve Jones. I will be your prayer warrior for the entire trip that we're there. We're praying now that God would bless this trip and make sure it be abundant to help everybody who need to be helped, as well as helping with the recreational activities there and whatever else we need to have done. Good to see you guys. See you on the trip.
Yes, thank you, Mr. Jones. And also he helped with the logistic and making sure things are done on time. So with all that training, we're going to rely with Mr. Steve Jones to make sure if the training is ending at 10 o'clock, ends at 10 o'clock. So thank you, Mr. Steve. Next, Dr. Mlungu.
Hello, can you hear me?
Now we can, yes.
Hello?
Yes.
I'm Dr. Mulungu, and I'm working at the hospital, anesthesiologist. We are looking forward to seeing you in Dar es Salaam in a few days to come.
Thank you very much, Dr. Mlungu. And Dr. Mlungu has been from the anesthesia department, and he has been helping us with the postpartum hemorrhage, working behind the scene, even helping us with the 3 of his colleagues to come and help us with postpartum hemorrhage. So thank you very much, Dr. Mlungu. On my screen, Dr. Akida, I know you just jumped in. You just 30 seconds to introduce yourself, Dr. Akida.
Okay. Good evening.
Good evening.
I'm Dr. Akida from Mwananyamala Hospital. Sorry for delay. I was forgetting about the timetable.
No, that's okay. Thank you for coming. Dr. Akida has been a contributor for the QHSC, one of the trainings she did with Dr. Msambichaka, and she's been helpful in discussing the process and how to, especially for the help baby breathe. So thank you for coming back. as I told Dr. Fabian Ngido, yes, we have a lot of pediatricians in here, but also all those babies require a healthy mom. And that's why we want to discuss about how to care for these moms in different hospitals and make sure they get the best care possible. So did I forget? She came back? Oh, Miss Christine, sorry. I didn't see her. Miss Christine?
Everyone, I'm Kristen. Anyway, so this is my third time going to Tanzania and I am so in love with it. I'm a school teacher. I'm working with the kids, and this year, Teresa and I are planning on putting together a nutrition program for the kids. So we're just getting started with that.
Thank you very much, Miss Christine. Yes, we already adapted her. She's been becoming also the fixture of QHSC. So thank you. Miss Valentine's our secretary, and then we can come to the program quickly. Miss Valentine.
Hi, everyone. So I'm Valentine, and I am, as Dr. Gaboni mentioned, the secretary for QHSC. I participated in last year's medical mission, and this year I'll be doing whatever I can from Florida. I just had a baby, so no traveling for me right now. But yeah.
Thank you very much, Ms. Valentine. Yes, we're going to miss you, but we're going to have face to face. You can see us doing the work. So thank you. Without delaying, thank you very much again for everybody being here. So I'm going to go through the program a little bit quickly so then we can get to the discussion. And I know a lot of people are at work, and for our colleagues in Tanzania it's in the evening. So I'm going to go a little bit fast in the beginning, just to give you the rundown. So I'm assuming everybody can see the agenda. So we usually, this meeting always go back to say with the training. So far we have quite a bit of training. So I'm just gonna give you a highlight. We don't need to go to details, but we have had training since the beginning of May. And the goal is to give the information now, and then later on you guys can, we can do the hands-on training without rehashing the whole theory part. So people at least will be prepared. And that's one of the emphasis I'm hoping you will get at the end of this meeting, is that all the training that we have done theory-wise, people need to review those videos if they have not seen them before they come to the training, because we will assume that you have received that knowledge. And then so when you come and we start doing the skills verification, we want you to be able to perform those skills versus not knowing what you expect. So we're going to resend those videos again this weekend. So people who are scheduled to come to do training, they need to be able to saw this video before they show up. We're going to review just a little bit quickly the takeaway from the meeting of August 5th. August 14th was postponed, and that's what we're doing today. So 2 weeks before that. Today, we're going to focus on the permission and connection of the hospitals and how we're going to do the process for the NSG. And then just a little bit finalize the schedules and to know who is doing what, and then give you a little update on the dry run activity. It means like we're going to try to run through the schedules, how we're going to do the training, and at least people can have a visual before the actual day. And then we are hoping the day that we arrive in Tanzania, September 12th, that all the leaders, people who I see majority of you guys are here, if we can meet at Luther House and then around 2 o'clock, so then we can get to know each other before the training starts. Because once we start, every minute counts on that training. So we'd like to see everybody else, just even if for an hour, to put the name and the face together, and just if there's any last minute logistic things, then we need to discuss that part. And then at the end of this meeting, we have like an open floor. So if you have any questions, then we let you go. As I said, logistic part, we did a lot of training. We did almost 9, and then the next one, the next training that is left right now is August 25th, which is the postpartum, the dry run. So that's the one which we are working behind the scene right now to make sure all the points that we need to evaluate on when we're doing the medical mission will be discussed that day. And as I said, we're working with Mr. Jafari, Dr. Gwen, and a few other people who are behind the scene, the OBGYNs, to make sure we address exactly what is needed to be evaluated. And that's also is going to include the use of the NSG. On that training. Takeaway from last meeting from the August 5th, we were hoping that, I think I saw Dr. Jarafa here. Mr. Saturin be able to give get the letter. So I did communicate with Madam Zuhura, and she sent me the stamp of the letter that was supposed to be, but they're just waiting to send us an official one with the stamp, so then we can use that as welcoming invitation letter to do those training for 4 days. We're still working with the NSG to buy them, but there's a lot of logistic and process that for that process on that side is on hold, but we're going to continue working on it behind the scene. However, we have other alternatives or plan B, which we're going to let Dr. Tilia, Dr. Mkonyi, and others to discuss about that part. Face-to-face training, of course, we are thankful. Dr. Mkonyi, Dr. Robert Mushiro, Madam Zura, and Mr. Jafari have already confirmed that the rooms are set for those 4 days. Thank you very much. So now we are still working on making sure we have those devices that we need to do to use during the training. We're going to ask Mr. Nicodem and Ms. Agnes to give us a little update about how to do the sterilization of the NSG thing. So we're going to discuss that part. And also if they have any update about the Mama Natalie and how many are they in from Tama, so we can have, because we need to have 10 stations. So we're going to let them discuss that. And then, of course, we needed to identify the process. As I said, Mr. Nicodemus is going to give us the process, how to clean and how long does it take and what the process is. That take 1 or 2 days, whatever. We're going to learn from him today, and he's here. Thank you. Also, on that discussion, we have to know who is going to be responsible, who is going to handle that NSG. So when we are planning on this thing, it needs to be known where, if I have the #1 NSG from Buguruni, it goes to Amana, and then it goes to Muhimbili. How is it going to get back, and who is going to have what, and who is going to be responsible for those that. So those are still the discussion behind the scene is done, and then we're going to report as we get them there. We're going to have, we did also, since we learned that Mana Hospital also is included in this secular use of the NSG. So then I was able to talk to Dr. Brayson Kiwero, for medical officer in charge from Amana, and we had a great conversation, and thank you very much. And I think he's here to the meeting. So we are able to include them and see more logistic things happen behind the scene. And I believe there's somebody from Amana, Sangalala, from Amana, so also we can have that discussion. So things are coming together, but a lot of stuff are done behind the scene. And as I said before, and I'm saying again, thank you very much for our colleagues from Tanzania for participating and give us the feedback and tell us, okay, this is not going to work, this is going to work, so then we can make it effective. Because we are all doing this because we want to improve the clinical practice and save those patients' lives. Also, last time we discussed that we were looking for somebody who we can have contact and who's going to be doing the scheduling. Thank you to Madam Zuhura. She has shared the name with Ms. Priscilla Kanayamagoha, and she's the head of midwifery and reproductive health department. I've already been communicating with her. Unfortunately, she had a prior commitment at this time, but we're going to continue communicating with her to make sure everybody who was the names were provided before is going to be scheduled. And of course, we're still working with Amana if they can spare a few people to come and get, either be the super user to be involved in this training. Then, as I said, behind the scene things that be done. Any questions so far?
Yes, I was just going to add, you mentioned the meeting on the 25th, but that there's another one, I believe, more than just wound care by Victoria Jones, burn specialist, on the 22nd of August for the training.
Oh, yes, yes, thank you. And I think I sent the invite last week, maybe Monday or Tuesday. Yeah. Yes, so that was is something that wound care, including like the burn units people or the people who are taking care of the patients with diabetes. So if they have any wound, how do you care for it, nutrition-wise, questions like that. That also has been, Ms. Victoria has been working with Dr. Mrema from Muhimbili, and I believe Dr. Benella has provided a couple of names from Mwananyamala for the people who are involved with wound care. And so we're going to try probably to communicate and then hope them that we attend on Monday, the 22nd at 7 o'clock US time, but in Tanzania it's going to be. Okay. We already discussed about the letter. Madam Zoe have already helped us to get that, and we're waiting for the other one. So things that we're discussing today, it will be the training with Amana. So Ms. Sangalala, do you have any update from there, if people will be able to come, or what is the process right now?
Hello?
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 Yes, we can hear you.
Actually, we just have received the invitation, the training to be held at Muimbili.
Okay.
Yeah.
Yes, so when I spoke,
looking forward for it.
Okay, good. When I spoke to Dr. Braces on Kiweru in the beginning of the week, he said he was going to work and see if some people will come. And so I wasn't sure where he's at and how many people will come. And he did request Madam Zura's number, which I did share with him on Monday. And then so we see how many people are you guys willing from Amana, and then we can add. So at the moment, I'm just going to share quickly a schedule. Sorry if it's moving too fast. I'm going to share the schedule like this. So this is what we are planning as of now. So if people are coming, just regular attendees are coming. So we have morning session and afternoon session. Morning session is from 8 to 10, and then 8 to 12, and then afternoon session is from 1 to 5. However, the morning session, the first 2 hours is the Help Baby Breathe, and then the second 2 hours will be the postpartum hemorrhage. So the Help Baby Breathe, those 2 hours, there we have their review or discussion, and then going to 10 stations. So the people will be distributed in 10 stations. So we are right now expecting at least each session, like morning session, we have between 50 to 60 people. That means we read that when we break it down to stations, so every station is going to have 5 people or 6 people. So that is manageable for when you're doing hands-on skills. So everybody can, if you have the money, everybody's going to be able to touch.
Maximum how many?
The same thing for the postpartum hemorrhage. Okay. We are working on it to try and get at least more Mama Natalie or Mama U. And then so an NSG. So the ANSG, we are hoping to get or borrow for training 10 of them. So if we have 10, so at least every single station, which you have 5 or 6 people, to have one NSG. So at least everybody can practice and make sure we have one person who is going to be a model for the group. And then we practice the application from on and off. The same thing if we are doing part of assessment like a fundal check. So everybody is going to be able to put their hands on to Mama Natalie and massaging their fundus. And if you're doing those assessing the blood loss from Mama U, then everybody should be able to do hands-on. Because if you have a bigger group, then you might not be able to I see Dr. Tia is asking how many people. Oops, hold on a second. Let me go back to.
How many
people from which section in Amana are from? So we're going to find out, Dr. Tia, we're going to find out how many people are able to come, and then we distribute them in this different group. Because we have 8 sessions. So 4 sessions for morning time, 4 sessions for afternoon. So 8 sessions for postpartum hemorrhage. And then so each session has 10 stations. So if we know the number of people who are coming from Amana, let's say I'm just giving an example, we get 10. Either we can distribute to one person added to each group. So instead of being 5, it'll be like 6, one group, and then the rest will stay 5. So we need to know the number that they'll be able to send to Muhimbili. So then we can add them to each group. I mean, for postpartum hemorrhage, you can have in one group, you can have 6 to 8 people. So I'm not saying that there should be 80 people in each station, but I'm just saying that is mathematically, then if you are thinking quickly, each group should have at least 6 people to 8 people for postpartum hemorrhage. For Help Baby Breathe, their groups is 5 to 6 because of whatever they're doing is they require the bare minimum number of people so they can have enough time to practice all this the ventilation and stuff. Does that answer your question, Dr. Tilia?
Yeah, thank you for answering. My question was trying to look on where they come from. They have to ensure that all the sections which will be dealing with the PPH should be represented. I mean, all the sections where the mother is more likely to receive care or the PPH can start should be represented, because we most of the time look on the labor ward, but with the other places where this woman can start having hemorrhage. So health workers, I mean, representation from these sections should be put in mind, so that once they are trained, every section will have somebody who has been trained. This is what I wanted to know, from where they come from. If they're coming from Amana, all sections which will be dealing with the PPH should be represented by those health workers. It's not that all coming from only maybe labor ward or where, but we know exactly hemorrhage can start anywhere along, I mean, where these women are in the hospital. So my concern was that one.
Excellent. So that Ms. Sangalala probably is going to help us share with also the Dr. Kiweru. So when I agree with Dr. Tilia that yes, we don't want to just train only labor and delivery people versus antepartum. We know that, or postpartum people. We know that people will be bleeding. So we do need, if we have that interdisciplinary groups are coming from anybody who's going to touch a pregnant patient, more likely, if they are able to come, then that would be great, because then they will learn the identification things that they need to identify immediate notification, so we can address as soon as we can. So that would be good. So as I said, that conversation might continue at the end, because I think Ms. Sangara just said they were just given the invite, but we can continue discussing that part within next week to know exactly what is the makeup of the people who are attending the training, to make sure that it's going to address, or they're going to come back and share that information with their sections. So then we can address it and identify early on that patient who might be at risk for postpartum hemorrhage or is experiencing postpartum hemorrhage.
Okay, thank you. We'll be there. We'll find everybody from each section who will be there. So
Okay.
we can come and have it.
Okay, and then so we can also talk, offline, and then we can discuss, because right now what they've done, the previous hospitals, they provided the names for us. So because every person who comes in, we just put their name in there and put on the record that they have done. So when we are giving those certificates for attendance, so then at least your name is already there. So you will give us the name, but then logistic-wise, arranging who is going when for training, that will be for you guys, because you know their schedules, I don't. So it'd be easier to do that. Anyway, if you do identify those people, would like to get their names, so we can have just for record purposes that these people have attended, and then we can verify if at the end of the day that for follow-up purposes who have been trained, so we can present, okay, these are the people who came in, these are the people logs in, people completed the training, people passed for whatever the verification or assessment, and then we can return that to the people in charge at the education purposes in their respective hospitals.
Okay, thank you. We'll be doing that.
Okay, perfect. Okay, so let's go back. As I said, for scheduling purposes, Ms. Priscilla Kinaya Magoha, she's working on it. And then also, if once Ms. Sagalala give us the names, so then we share, we make sure we have like a master list of everybody else who've been trained. I think that's what Dr. Tilia was relaying for. We want to know who has been trained and which department, so then we can follow up, and it'll be easier to say, okay, we train 10%, we train 50%. All those things are statistically needed, so we know who is training, who is not. And then so when we have what they call, I found out in Tanzania, they call TOT, train the trainer. Here we call the super users, or but that is the terminology, so we're going to start using it. So then we know who is left to be trained. So once the medical mission is over, we don't want the education to be over. We want the education to continue for the rest of the time. And then so that's why identification of people we need to know, and their follow-up needs to be done. So thank you. Mr. Nicodem, do you want to explain to us a little bit about the sterilization process of the NSG, what it takes?
Yeah, I passed this through and different sources and the infection prevention and control guideline of Ministry of Health in Tanzania, there is no such kind of NSG, but
okay.
we could buy in the material related to that. It's a fabric material, no. So it is the disinfectant that used is a chlorine solution. Chlorine solution, it is available in our hospital, and it has to be in 0.01%. So what is changed is just steps. Previously, we used it to expose it to chlorine solution, so 0.01%. But now it is changed. We need to make sure that we do pre-washing of the device before exposing it to chlorine solution. So what we'll be doing is in 5 steps. After having used the NSG, then you do pre-wash. If there's a blood or any contaminant, you remove it, and from you wash it with detergent, is the soap and running water, and then after that you put it into chlorine solution 0.01 for 10 minutes, and then you remove it. Then you should remove the chlorine solution, because if it will remain in the NSG, it could demerge. So you need to remove it, putting it into soap water, and then after putting in soap water, then you put it into clean water, and then you expose it to the sunlight, so it's for letting it to dry. And that is what is done. And then maybe what we discuss here is just what could be the storage mechanisms. Maybe you could use the cupboard that we have, the cupboard that we have, or what is your insight? But it should be put somewhere which is enclosed.
Okay, before I answer, I think Dr. Tia, do you have a question or comment?
Yeah, I have a comment.
Yes.
It is exactly that the solution is 0.01.
Okay.
And after you have rinsed it, then before you use soap. So you soak it in the chlorine, and then after that is when you start washing it by soap. And it can be also used, I mean, washed in a washing machine, but the washing machine should not dry or should not be included with the other linen in the washing machine. And to dry it, you have to spread it not under direct sunlight, because it can destroy the fabric. So it has to be in a which can change the texture, and it can start destroying it, the strength. Always that it has to be stored, I mean, in a place where it's readily used. So it should be exactly at the ward or at the labor ward, in a easily reached by anyone. It should not be put in a cupboard and which is locked or something like that. We need it to be readily accessed. Thank you.
Thank you very much. And that was my next question, and you answered already, Dr. Tilly. Yes, so.
But also maybe something to clarify, this recent guideline, yeah, that's what was narrated by Dr. Tilly, yeah, pretty correct. But the recent guideline is, sometimes NSG could be exposed to the blood. And now it is recommended that any bloody or solid material, which could be maybe urine or vomitus or feces or blood, should not be directly come in contact with chlorine solution, because chlorine molecules are very low and they are directly binding to protein, any kind of material. So if you expose directly to the NSG, which is not pre-washed, then the chlorine will bind to the what? To the blood, or those matters that is involved, but it's contaminated, which has contained protein, which will deactivate it. So the disinfection intention that we intend will not be achieved. So that's why now from the 3 steps, we change to the 5 steps, that the pre-wash start and then followed by the what? But the exposure to the disinfectant with chlorine. That's if you use chlorine. But if you use the other disinfectant, then you could consider based on the manufacturer of those disinfectants. And that's an update, recently updated guideline from the Ministry of Health and WHO.
Okay, thank you very much, Mr. Nicodem. So once all the things that are cleared, those steps needs to be made, or usually we always call like nest badge. Means like you laminate it and put it for whoever is going to be cleaning those NSG. They have to have readily available in front of them. Then they can follow those steps as you said. And if that's the guidelines for correct, I mean, right now, so then yes, every single person who is touching it, that's NSG, have to follow those steps. So that would be great.
Yeah, that is as usual, as normal processing of those instrumented devices that you have. And that could be added on top of that. We should also insist it. We can do HBB very good, but in turn we could expose people, babies into the infection. So that's why also we could maybe have with some certain minutes and instructing those participants on how to do a high-level disinfection of those resuscitation equipment, because if we are not resuscitated well, they do always harbor with negative microorganism specific bacteria, so they are just causing infection to the babies. So that could be go parallel. That on top of what we are doing, those infection prevention control should be added on top, because it's a number 3 killer of the leading to newborn and maternal as well. So we need to address those direct causes. We need to address those direct causes, because also the service could lead to some secondary to infection of the baby, of the mother and the baby as well.
Now that's an excellent point, Mr. Nicodem, because I agree, when you have reusable item, that sterilization is the key, because you're going to transfer infection from one patient to the next. So definitely that one will be an emphasis included in the training, that everybody at least needs to know those are the things that need to be done. Even if you don't work in the sterilization department, but still, if you have that item, you need to be able to be aware who is going to be pre-washing it and who is going to be using that item. How are they going to secure that you don't spread it all over the place when it's going, because we know the patient is going to be bleeding. That is the goal. I mean, every single person who's going to be put in there, they're going to be bleeding. So how much is going to seep through on the garment needs to be cleaned before the next patient comes into contact with that part. So thank you for sharing that part. We're going to continue working on that. As I said, we're going to try and work and make sure we get a little badgy laminated short, something that it can be distributed to people, so then they will know for sure these are 5 steps as you suggested, and that's how it's going to be. If it's that's how the Ministry of Health is recommending, then we're going to follow whatever the guidelines is in place, and to make sure that everybody follow the steps who is touching that part. My question is, how long does it take? Let's say I come from Amana or Mwananyamala, I drop that NSG with a patient at 12, and you gave me the newer one or the clean one. So how long does it take for you to clean that one from the beginning to the end?
The cleaning it takes more than not more than 20 minutes, because the step that takes more minutes is exposure of the device or equipment into chlorine solution. That's 10 minutes, and then the other steps are just 1 minute, so to say 2 minutes, and then it's done. So, but I don't have an idea on how long it takes to dry. Maybe Dr. Tuya could share with us, because he had been used to those NCG.
Dr. Tuya, go ahead.
Yeah, the drying will depend on the weather condition and where. For example, in Dar, it might take less time, but it's not less than 2 days. In other places, it's more even 2 days, because
your audio is cutting off. Dr. Tilia?
You can put it really dry, but you are shortening its efficiency. It might not be able to last its sun, and that's why also we always. Yeah, do you get me now? You get
yes,
me?
We can hear you.
You hear?
Yes.
That's why we recommend that the facilities should have enough garments at storage for replacement. So the receiving facilities where the definitive treatment is going to take place, have enough depending on the facilities, which refers to their level.
So thank you. That was my next question. That's why I asked how long does it take, because we have to think if Muhimbili has, I mean, just an example, Muhimbili has 4 and one of them takes 2 days to dry. So if Amana bring a patient or 2, Mwananyamala bring a patient or 2, those are
just
4.
Because it's the place with the garment where it takes longer to dry up.
Yes, so I mean, I think the logistic part needs to be done is like to figure out
It will,
how many
it will
people...
not be good. It will be done.
Go ahead.
Yeah. Yes. For example, what we did for the facilities, for the numbers of the garments, the facility like Yamana, for example, we have 6 to 8 pieces. And for health centers, not less than 4 pieces. Yeah.
And how many does Muhimbili have?
Muhimbili is supposed to have even more than 8, 10 to and above, because of
Okay, so my question also for
cases, the referrals, even other cases, and they might need the NSG.
Okay, I see. So a place like Muhimbili, Buguruni, which is one of the health centers, so that will be 4 of them, at least 4.
Yes.
Okay. I mean, at least that's to give us an idea of like how many, as we were discussing, to know they're needed. Because I agree, if one garment takes 2 days, and more likely, I'm assuming in a day, those hospitals that we're discussing right now, Amana, Mwananyamala, they might have probably 1 or 2 patients. So those are already, they'll be the ones that are in Muhimbili will be used or done exchange. Why, if another hospital send from Temeke or wherever send a patient, it's not going to be, they're not going to have an exchange one. So I understand that, but another area which we already discussed, Dr. Tia mentioned, who is going to be accountable. So once the sterilization department finish cleaning up, they're going to have to go back to the labor and delivery, because that's why they're receiving a patient. So wherever the location that you guys are receiving a patient, that's the location that those cleaned or ready to be used garments have to be there, because that will be an easier exchange. So you bring the patient, they accept the patient, you change from one stretcher to another. That's the time the escorting team have to leave with a clean one to where they came from, like wherever the hospital they came from. So that's the area that we need to find out from each hospital. And then, so then we'll give them the responsibility of that to make sure they have the standby NSGs, and then they should be able to exchange when they're bringing a patient. So that's ongoing on the side. And also for Amana, if we can find out, that would be great. And then Buguruni also, we need to get the information, because that would be like a starting point from Buguruni. So more like it has to be in the labor and delivery, where if the patient needs it, it's readily available. So the next section, which is, ongoing training. So we are discussing that, yes, we're going to do those training for 4 days. And then after that, we are hoping people who are there, some of them are super users or TOTs, or they will continue. Our very own Mr. Jafari, I'm sure he's going to have his hands full, continue training other people. But also we need to know who else can continue training Amana, Buguruni, Mwananyamala, and all those around hospitals. So that's part which Dr. Mkonyi and I think Dr. Tiria have been discussing about, including the training of trainer people into the this training, the 4 days training. And so they might get more training than the regular attendees. So when we leave, then they can continue training, have a more background information to be able to train. And our goal is we want to make sure everybody shows up there, should be able to touch that garment and be able to apply and apply on and take it out, just to make sure they know how to use it anywhere that the pregnant patient who may need to be placed on that garment, that person knows how to do it and do it safely. So to make sure we prolong the patient will maintain this complications to a higher level. Mr. Nicodem, you had your raise.
No, I just wanted to apologize that I have some emergency, so I have to reach somewhere this just 2 minutes to come, so I will not be able to go on.
No, that's okay. We appreciate that. We appreciate. Yeah. If there's anything, I will let you know afterwards. No, thank you.
Thank you, too.
Okay. Dr. Tia, go ahead. You said you want to discuss. Dr. Tilia?
Hello?
Yes, go ahead.
Yeah. For NSG planning, the first, according to how it is, we normally have a theory part which we can orient people to know what it is. But the second part is to have hands-on, and you would like for participants to know it and very well without any problem, and immediately after the training they will be able to apply it. They need at least a whole day practicing hands-on, depending on the number. So that's what we think. But as you say, you talked about the TOT. What we normally look at is, for example, when we are training the health workers like this, we also spot those who are, for example, they understand very quick, and they at least they perform very well on the hands-on and all that. So we build on them to make sure that they can be able to train others for that. That's what we normally do, because we can say that for most of the time, in the beginning, we trained those who are from the district level to come and train. Some of them, they are too busy to train, and we would like most of the time to have the trainers who are the ones who are performing it in the facility. So yesterday I was attending a woman in a PPH. Tomorrow I'm going to teach somebody on how to manage this patient. This is what we see, that the TOTs could be in that group, so that they practice it every day, and they keep on updating themselves with the use. So that's how it is. So for TOT, to know who is the TOT or who is not, will come up from the training itself when we are training, and we'll be observing them and trying to see them.
I agree. I'm going to let Mr. Jafari, and then I'm going to respond to that. Mr. Jafari, go ahead.
Thank you, Dr. Tia, for that input. Actually, it's a nice thing that you have spoken, and I have a suggestion on that, because when you were talking about the theoretical part on that, as you can see, our timetable that we have been planned before, and NASA just come up as an part of management of PPH. So it's on as its own. It needs some time to learn on how to use it, and actually how to disinfect it and reuse it again. So if possible, if we can do that before, it will be much better for a theoretical part. And when we come to physical training on as a part of management of PPH or management of shock, actually it will not take much time compared to when you introduce something like that, which is actually new for some staffs, and it will not be easy for them to cope compared to others who are capable to catch up easier. So as my suggestion, if we can do a theory presentation for that, on the part of it and how to use it, then on the part of skills, and just a minor part of theory when we do a physical training.
Thank you, Mr. Jafari. I agree with you. And that's the other of the logistic part going on in discussion right now, is even if we have those 4 days for general attendees, we also have on the side running simultaneously with that for the train of the trainer. So we are working on behind the scene to try and see how many people either we have the first day, and then like what Dr. Tilia was talking about, spot people who you think could be super users or trainers, and then in between when the Help Baby Breathe continues those 2 hours, then we have extra information. Because in order to be a trainer, you're not going to have only these 2 hours like with the general public. You have to have specific more information, insight of things that why do we do that exactly in depth to be able to teach it. And I agree with Dr. Tilia that we want those people, the trainer of the trainer, to be among the people who are working with it, because when they're actually taking care of the patient right then and there, they will be able to do it right then and there at the physical location, versus having a trainer from another place come specific a day versus somebody who is actually doing an actual time when the patient is experiencing. So those are the ones, because you can train by experiential right then and there. So that's why a lot of logistics, I said, are happening within a week. We definitely have to be able to include those information of what you are saying. The theory part has to be included and added to the training before we get there on the hands-on. And then also for the postpartum hemorrhage, there's a training on the 25th next week. So if we're working on the content right now, I know we're always limited for 1 hour. So if there's content is more than that, and what Mr. Nicodemus was telling us about the sterilization, it needs to be included. If we think it's too much, then we can break the 25th and then another following Thursday again to get the second part. So content will be more, and we want everybody who is going to come to the training have those 2 classes, including the previous one. So it'll be 3 classes to be able to prepare for it, because there's a lot of information. Postpartum hemorrhage, you cannot teach it in 6 hours. No, that is caused by itself. So we try to get the most applicable information and then condense it and be able to teach it. But also, I agree with you, they need more theory behind it. Because some of them have never seen the item, but some of them have seen or heard about it, but never apply. And some of them have used it before in different places, but they don't have it here. So it's like almost they need to refresh their skills. So there's a lot of variation between the knowledge of how to apply and this item, which is a life-saving item. So I agree with our suggestion, yes. Do you have something else, Mr. Jafari? Mr. Jafari? If you're speaking, you're muted. No?
Oh, sorry, I was speaking out of mic. Yeah, I think that's okay.
Okay, that's good.
Yeah.
Dr. Tilia, do you have anything to add to that? Or Dr. Matham Konyi?
Asante. So I think there's a lot of discussion that is happening and a lot of it on the background. So I think as time goes along, we'll find the best way to have the training so that we offer training that is compatible with the ministry requirement, but also people to be comfortable and competent to train. So it's good that we have here the concerns from both parties, as in the users and the people that are behind the scene on the gamut. I call it VASI. So as we go along, I think we'll be able to come up with the best plan that will be suitable for everybody, including a wider audience, as the way I like to complicate life.
No, but we do need to, that's why the reason of the logistic meeting, because we want to be able to learn all those little things that needs to be addressed to make it more effective, because we don't want to just come there and find out whatever things we are sharing or we are doing is not applicable. That's not, we don't want to waste your time and we don't want to waste our time. So we want to make sure something is applicable. And so this discussion, and I do appreciate every single one of you guys who show up today for this discussion, because we learn a lot of stuff behind the scene. And so if you voice your opinion, we do want to hear it so we can make it better, because this is for all our healthcare workers, all our colleagues, and especially for our patients, because that's our goal of all the nursing and medical background. We want to make sure the patients are safe. So if we can implement something that is going to improve the prognosis, then please we need to do that. Dr. Akida, go ahead.
I have small concern. Maybe I missed this information because it has been a while since I joined this program. So my concern is it shows from the timetable we have HBB group and PPH. So in the list that we sent, we have pediatricians and OBGYN specialists. So my concern is, I'm just imagining myself in the PPH group. I know for the nurses it's okay because they are usually being reallocated.
No, I understand that. That's why I was teasing Dr. Fabian, before. I said, even if you're a pediatrician, I'm going to put you to PPH to learn and teach somebody else. No. So if let's say we have, I'm just going to give numbers for the sake of illustration. So we have 30 people from Mwananyamala, 10 of them are pediatricians, 10 of them are, no, maybe 5 of them are OBGYNs, and then maybe 15 nurses, midwives. So when you're doing Help Baby Breathe, everybody should do that. But everybody who's going to touch the mom and the baby needs to know about the baby. So then that's fine. So then when you're coming to the moms now, so as a pediatrician, you might say, oh, maybe I don't need to be there when they're doing the PPH. But remember, for example, if you're going to need that information that if the patient is bleeding, the mom maybe is bleeding before abruption or whatever, and then they're going to end up with postpartum hemorrhage, or they're pregnant. So you are going to be thinking of your baby who's going to come out compromised. So things that they're doing during the antenatal bleeding, they might be helpful for you to understand this is what I need to address. And then so after the baby is delivered, yes, you're going to take the baby with you, or with the family member may ask you, okay, what is happening to the mom? So mom is bleeding and they're addressing the postpartum hemorrhage on mom. As a pediatrician, you'll be aware of like things that are going on if mom is experiencing postpartum hemorrhage, and you can lay that information. When you're getting that information, does not mean that you have to come and participate in postpartum hemorrhage, but it's just probably the knowledge part where you are there. However, if you cannot do that part, then those are logistic things that we need to discuss right now, and then you don't have to attend it to the postpartum hemorrhage. That is okay. It depends on what you guys or your hospital wants to do. I can see Dr. Mkonyi raise her hand very quickly because she's trying to run away from postpartum hemorrhage. Go ahead, Dr.
Yes, I do want to run away. So I think for the sake of knowledge, for me, it's also important because at times I'm also called to receive a baby when a mom is having a massive bleeding, and I usually let the midwives do what they can do the best, and they let me deal with my baby because that is where my best hands are. And I'm glad that this training is organized in such a way you have a prior knowledge or training prior. So I can assure Dr. Akida can watch the lectures or the training on the YouTube, which I'm going to do as well, on the management of PPH, and I'll also try just to see how that lovely gamete looks like so that I can explain to relatives. But I'll probably leave a chance for the midwives to be on the training so that they can benefit more, and I won't take their space.
No, we do need the models to be on the gamete. So even if you might not need to participate on the PPH, you can be one of the model. So we can apply the NSG on you, Dr. Mkonyi, on and off. So then let the OBGYN midwives and nurses come and practice on you under massage.
If you promise my blood pressure won't go up, I'll do that.
No, you'll be fine. You'll be fine. We're going to need people because we don't have enough Mama Natalie to have those 10 people practice to put the Mama Natalie on the NSG. So we're going to need one of the attendees to be the model, like this is climbing on top of the bed, and we strap you on, like on the example in the video, they were using a person who they cover everywhere, so you don't know if it's the male or female. But so we'll use, if there's one pediatrician who is on that group and might not maybe need to practice how to do fundal massage, then yes, you can be there. We can use you as a model to strap you the NSG, applying on and off, and you can tell us how tight it is or how loose it is, so at least you can get the feedback from one person. So it's always helpful to work together. Yes, Dr. Tilia, yes. the NSG, we did share the video how to apply the NSG using the steps 1 to up to 6. And then there was a demonstration, and we're going to include again with the same training next week to make sure everything is addressed. And yes, so the application for NSG, it's very, very simple, but it's systematic. So you cannot skip a step. And then they explain exactly, put it on this number 1, 2, 3 up to here. And if you're taking out, you have to do 15 minutes vital signs. So all those things, we have created a little laminated, a little badge. So people will know, okay, this is how it says, this is how we need to do. And once you do 2 or 3 times you practice, it's very easy because it's, you know, I mean, systematic 1, 2, 3 up to 6. And then if you're taking it out, the same thing, 1, 2, 3 up to 6. So, I mean, it's very self-explanatory, but we get enough chance to practice. And that's why having a small group of people in each station will help, because everybody's going to be able to put it on and take it out, just to see how it feels. And sometimes for practice purposes, you can do 2 people. So you put the left side, I put the right side, and then at the end, so at least you cut down the time. And then if you have 6 people, it means you have to do 3 times, and everybody's going to be assessing, okay, this is too much, too tight. Did you put your fingers? Is it tight enough or whatever? So smaller group of practicing gives you more chance to review and make sure you know what you're doing. But it's a very simple and easy way to follow, but you have to follow the steps. You cannot skip the step. Okay, so for the part of the discussion, that's what I had on the on my agenda. Other than the schedule, I mean, we knew the schedule. As I said, it's 4 days of the schedules, and starting from 8 until 5, 2 sessions. So when you come in, let's say one of the attendee comes in, you just attend only 1 session, the 4 hours block, and then except for the trainer. So those are the ones who are going to probably be there all 4 days. We're going to work with them in between, give them a little extra content, and then bring them to the class and give them a little content again while they help baby breathe continues. The trainer is going to do something different, and then add them to the group. So by the time we get to day 3, then they should be able to practice and help us to run those the last few days of assessing. So that's how you get the theory, you practice, and then you facilitate so to complete to be trainer of the trainer. Here in the United States, it's like a preceptor. So you'll be able to lead the training and educate the next person. But I said more logistic stuff are continuing. Okay, with the rest of the group, and I mean, again, thank you for coming. What else, any suggestions, concern? Dr. Fabian Guido?
Hello.
Hi.
Yeah, I mean, I don't have any big suggestion, as everyone said. I mean, I think we just need to know the numbers of people who are coming, so we can plan the sessions, knowing if there's now people coming from Amana, then we can add them and then try to figure out class and how many baby Natalie we need to have. Yeah, so it's what, about 3 weeks away. So if people could send you names, so at least we have exact number, number and the names. So at least we can assign people tables. So when we get there, when we meet that Monday afternoon, we basically know who will be on what table and who will be there facilitated for the table.
Excellent point. So right now, that's where we have Miss Priscilla Inayama Hoga. So she's working on assigning people. So as soon as she gives me that assign of each group, how many people, like 50 people are coming on each day in each session. So once you give me that, then we do that. And that's why I wanted the name, so we can have like each station, you find your name when you go to that station, you know who is the facilitator. I agree with you, yes. So we are finalizing that part. Even if Amana give us people who are coming, I'm just giving an example. So right now we are planning as 5 for each station, because that's 50 people per session. So even if Amana adds people, let's say they're adding 50. So great, so 50 for 8 sessions. So more likely we can add still 5 on each session, but then maybe only one group will have 6 instead of 5. You know, so it's not going to change that number that much, but at least it's going to be, instead maybe 5 is going to be 6, maybe maximum 7, but at least, yes. So, but still we need to know the number. I agree with you for surprise purposes.
For those people who are going to be coming, maybe they needed to watch all the videos that have been recorded first, so they won't be surprised because we'll have to move fast. It was only 2 hours, so.
Yes, that's the discussion we've had, and with the medical officer in charge, and we were discussing yesterday with Dr. Mkonyi. Yes, everybody has to review those videos, and that little, remember those questions you are creating. You're trying to trick me. So then we want people to complete, and then for them to get a little paper saying, yes, I finished those things, and then you can come for the training. Because that is just to ensure that when we are talking, we assume everybody's in the same level. Because you don't want people to talk over you, give you so much information, you have no idea, and it's wasted. Those 4 hours are wasted. But if you come in prepared, you're ready to go, and then people will be able to you're going to be able to learn and be able to perform well. And then at the end of the day, when we said, yes, so-and-so have attended this training, then it makes sense because you got what we prepared for and you're going to be able to use it. Dr. Mlungu, any feedback? Today you're very quiet. Yes, Dr. Tilia. Jafari.
Nothing.
Nothing. Anything, last one?
Nothing. Thank you.
You're welcome. I'm going to get the 3 names you put me down. We're going to include them for the training next week, Dr. Mlungu.
Okay, no problem.
Okay. Miss Agnes, Hadija. Everybody's quiet. So again, thank you very much for everybody who came, and we're going to share this video, and we're going to send the list of all the education that we've done so far to make sure people who are coming are able to view and give us at least some indication that they have viewed those videos. So by answering those end of the video questions, there were only like 5 questions, I think. 5 or 6. So if you can answer those, at least you know you've seen those video and then have reviewed the content. So when we are doing the verification of the skills, everybody is aware of what we're doing. So any leaders who are in here, please encourage them to view those videos so you can help. If Ms. Sangarala, if you can help us for Amana, for them to view the video. And if you can send me your contact information, then I will send you the link for those videos so you'll be able to share with people from Amana.
Okay, I'll do that. I'll give you just now.
Yeah, so my name is on like WhatsApp. You can just search Hi to Gabonia, so you'll be able to text me, or you can send me through the email. That's fine. Dr. Gaboni QHSC@gmail.com. And then so I can send you the information. Last one, if you can do the same thing, because I don't think I have your contact number, so I can send you the links of all the previous videos.
Okay, thank you. I'll do that.
Okay, thanks. So if you guys don't have anything else to discuss other than what we just did, I'm gonna let you guys go. Thank you very much, everybody.
Thank you very much.
Yes, thank you for coming. And we'll schedule again another one next week, same place, same time.
Thank you very much.
Bye. Okay, bye, guys.
Bye.
Bye.
Bye, and thank you.
You're welcome. Thanks. Bye, Dr.
Bye, everybody. Have a wonderful day.
Thank you. Bye, Dr. Guido.
Bye.
Thank you, madam.
Thank you very much, Mr. Lasonia. Come
Thank
back.
you.
Thank you, Dr. Akida. Thank you, Mr. Jafari.